Hi, everyone. Hello and welcome to NOAHE Round 6. This is session 2. My name is Erin Kerwin, and I'll be facilitating this session. So please join me in welcoming our presenter, Dr. Mike Paulden. Dr. Paulden is an associate professor at the University of Alberta's School of Public Health. And today's topic is an evidence-based approach to CADTH's cost-effectiveness threshold. So before we begin, I'll go over a little bit of event housekeeping. So participants will be muted throughout the webinar. To submit any questions during the webinar, please use the Q&A function. I'll highlight that the Q&A function is different from the chat function, so please look for that Q&A at the bottom. And the Q&A answering your questions will be facilitated during the final 20 minutes of the webinar, so we'll get to your questions at the end. So thanks again for joining us, and I will now hand it over to Dr. Paulden.
Hey, thanks so much, Erin. Thanks very much for inviting me. I'm delighted to give this webinar. So today we're going to be talking about moving towards an evidence-based approach for CADTH's cost-effectiveness threshold. So as most of the people on this webinar will already know, CADTH has a benchmark of $50,000 per QALY for when they do conduct economic evaluations. And there's a question about whether that's an evidence-based threshold, and if not, then how can we move towards an evidence-based cost-effectiveness threshold? I should also say before we begin that, that this is a really vast topic. And so what I'm going to be presenting today is really just a very sort of brief summary of this topic. There's a lot of complexities that have had to have been we're going to skip some of the complexities here. So if any of you have any further questions about any of the material that we talk about today, please let me know. We can talk about it after the seminar. There'll be some further links, some references that I can share on these things. And I'm pitching this seminar at an audience that maybe hasn't done any previous work around cost-effectiveness thresholds. And so we're going to talk about some of the fundamentals, some of the principles about how you would determine a cost-effectiveness threshold. So first of all, before we do anything else, why is economic evaluation important? And we're going to start off with a stylized model of a public healthcare system, which has a constrained budget. Now, as everyone here knows, in Canada, things are much more complicated. They always are complicated in Canada. So every province and territory has its own healthcare budget. And even within a province, there will be numerous budget silos. So this is a simplification, but it illustrates the key point. If you have a healthcare budget and there is a new health technology that is funded from that budget. In some cases, a minority of cases, the health technology will be actually cost saving, right? Could be a vaccine, some other kind of public health intervention that actually saves us money. And in that case, we don't need to think about a threshold, right? If it improves health and it's cost saving, we just adopt it. It's a no-brainer. Cost effectiveness threshold comes into play when a new health technology imposes incremental costs on that healthcare budget. So we have those dollars leaving from the budget to pay for this new health technology. And of course, there's a consequence for that. Well, first of all, before we talk about the consequence, why do we want to adopt the new health technology? And that's because this health technology is expected to improve the health of the patients who receive that technology. So we have these expected health improvements. And that's why we're all here, right? That's why we do health technology assessment. That's why we even talk about drugs and other technologies in the first place. Is because we expect them to improve the health of the population. And so these technologies are desirable, right? We want patients to benefit from these technologies. However, there is an incremental cost associated with these health technologies. And so within a constrained budget, that means that there has to be a consequence and there's less funding for other healthcare. And there's various ways that this can manifest itself. There might be less funding for other healthcare. Longer waiting lists, delisting. Even if there aren't any longer waiting lists or delisting, even if there was some additional money that was added to the budget, you could use those dollars for an alternative investment opportunity. There is always an opportunity cost. Whenever a dollar is used for one purpose, you've foregone the opportunity to use that dollar for another purpose. So there are foregone investment opportunities. And that means that there are expected health losses. right? So by foregoing the opportunity to spend those dollars reducing waiting lists, or investing in other opportunities to improve the lives of patients, as a result, there are expected health losses. And again, this is a very stylized model, but the same would be true if you had multiple different budget silos. The same would be true if you didn't have a single payer system and instead you had a system based on private insurance. It would be a little bit more complex, but there has been work done in the United States looking at, what are those expected health losses when a expensive technology is funded within a private insurance plan, right? Maybe premiums have to be increased to pay for that. Maybe some individuals then drop out of insurance as a result. And then there's a health loss as a result. So although this is a very kind of stylized model, this does apply to a wide range of different scenarios, right? There are expected health improvements from the new technology, a good thing, but the greater that incremental cost, the greater that foregone opportunity we have to improve health in other ways, right? And we have these expected health losses. An economic evaluation allows us to compare these and consider the expected net impact on the overall health of the population. And we need to emphasize here that when CADTH does their clinical reviews, right, they're very well conducted clinical reviews, they are not considering the clinical impact on other patients that arises as a result of the costs due to reimbursing the technology, right? They're only considering the direct impact that the technology provides on patients. They're not thinking, okay, well, reimbursing this will require reducing healthcare for other patients, and there's a clinical impact on those patients. That does not come into the clinical review. It's only within the economic evaluation that the full net impact on health is taken into account, or can be taken into account. You need an evidence-based threshold in order to do that, as we are going to see. The other thing to emphasize at this point is that the purpose of an economic evaluation should be to consider the health of the population. We're not accountants here, right? We're not just adding up costs for the sake of it. The focus is not those dollars spent. The reason that dollars matter is because those dollars could be used to improve the lives of other patients. And then the greater the dollars required for a new technology, the greater the impact on the health of the population. That is what matters. Right? At the end of the day, this is all about patients. It's all about the health of patients and the health of the overall population. And doing an economic evaluation is essential if all patients who are impacted by a recommendation from CADTH are to be given a voice at the decision-making table. So those patients whose healthcare has now been worsened, they're on a longer waiting list. Maybe there's a delisting of a treatment they require. Maybe they could have benefited from one of those alternative investment options. Those patients, I think, deserve a voice at the decision-making table like any other patient. And it's only by doing economic evaluation that all patients who are impacted can have any kind of voice at the decision-making table. Okay, so how do we consider whether a technology is cost-effective? And if you adopt a health payer perspective, this conventional public health payer perspective that CADTH adopts in its reference case, then a treatment is considered cost-effective if its reimbursement is expected to improve the overall health of the population. So in this case, you can see there's a much greater expected health improvement at the top of the screen than the expected health losses at the bottom. We can reimburse this, then sure, some health will be displaced elsewhere, but we gain more health than we lose. And so as a whole, the population is now healthier as a result of adopting this, reimbursing this intervention. Now, the flip side would be maybe this technology is not particularly effective, or maybe its cost, its incremental cost, is very high, or a combination of the two. And in those cases, the treatment would be considered not cost effective if its reimbursement is expected to diminish the overall health of the population. Okay, so that's sort of a very high level view of certainly how I and I know a number of other health economists think about economic evaluation. And you can see a very clear moral case for considering economic evaluation here. But of course, none of this works if the threshold that we're using to determine if a drug is cost effective or any other technology is cost effective is not evidence-based, right? If you just use some arbitrary threshold, well, then you have no idea whether a technology considered cost effective according to that threshold is going to improve the health of the population or diminish the health of the population. So it's really important to have an evidence-based cost effectiveness threshold. And in thinking about what evidence we need for that threshold, the real question here is how much health loss arises from the incremental cost of new health technologies. So what is that health opportunity cost? That's the language that health economists would use here. So if, for example, if a new technology has an incremental cost of $1 million and that's imposed on the budget of the healthcare system, what else could you have done? What else would have been done with that $1 million? And how much health would it have produced, right? That's the health loss. So how do we go about estimating this? And this is a relatively new area of scientific research. It requires empirical analysis. It's only over the past decade that studies have been published that have done this sort of empirical analysis. So this is a really exciting time to be thinking about this question, right? This is new work. And just last year, a systematic review was published that looked at these peer-reviewed estimates that have been published worldwide over the past few years. I was a co-author on this paper. The lead author was Laura Edney from Australia. And what this paper did was it identified a number of studies around the world, peer-reviewed, published in a variety of different journals, that had tried to estimate the incremental cost required to lose one quality-adjusted life year, one quality of population health. So you see this term marginal productivity. You can see it's in the title of the paper, marginal cost, right? We're looking at the margin of that healthcare system, given the budget that's been allocated, given all the different ways that that budget has been spent, all the inefficiencies within the healthcare system as it stands. At the margin of that system, how much incremental cost can you impose on that budget before you have displaced one QALY? You could also think of this as, okay, imagine you were to increase the budget. How much would you need to increase it by in order to gain one QALY, right? So that's the marginal productivity of the public healthcare system. And that's what these papers are trying to estimate. So let's look at the first of these. And I'm going to focus on 4 of these papers. The systematic review identified more than 4 papers, but some of those papers were in countries that are not really comparable to Canada. So, as many of you know, the PMPRB in Canada has a list called the PMPRB 11, 11 countries that are considered similar to Canada in terms of their GDP, in terms of their medicine market characteristics. So we'll focus on only those countries, right? Because some of these studies were done in developing countries where, healthcare spending per capita is far lower than in Canada. And as a result, the cost effectiveness thresholds that you would have are going to be much lower than in Canada. I don't think they're particularly relevant for informing any kind of debate about what CADTH threshold should be. A couple of those studies also didn't look at the QALY. They looked at cost per DALY averted. We're interested in the QALY in this case. A couple of the studies did not look at the healthcare system as a whole. They just looked very narrowly at hospitalization, right? And what is the cost per QALY of only within hospital reallocations of resources. We're going to look at those studies that focus on the healthcare system in general. And there's 4 of those studies in this systematic review. The very first was some seminal work that was done at the University of York by Carl Claxton and colleagues. And that estimated that within the NHS, as it stands, with all of its inefficiencies, we would expect one QALY to be gained if you added about £13,000 to the budget. And conversely, if you reduce that budget by £13,000, you'd expect one QALY to be displaced. What that means is, if you have a constrained budget and you were to spend £13,000 on a new technology, well, you're going to have to take the resources from that budget and you would expect to forgo one QALY. I should also say before we go on that these methods are new methods. No methods are perfect. Over time, these methods will be developed. There has been some debate in the UK between the University of York and the Office of Health Economics and others debating about, whether these methods can be improved. There have been some further analyses done by the folk at the University of York. They were not included in this systematic review, but I can tell you that the estimates they've got from these reanalyses that have addressed some of these concerns are in the same ballpark, right, of £13,000 per QALY. But absolutely, over time, I would expect these methods to be improved and the estimates to be revised. The other thing is that all I've reported here is the point estimate. There's a whole section in the appendix of this report talking about the uncertainty, talking about the probability distribution you would have around that estimate. So we've simplified things for this presentation, but things are not simple, right? The methods used in this report are very much not simple. It's a very detailed report. And yeah, these methods will improve over time, and these estimates will be revised over time. The next study that was done was in Spain. So again, this is another group of researchers based at a university in Spain. They published in a different journal, peer-reviewed study. They use slightly different methods. Of course, they're using different data sources because they're looking at the Spanish NHS rather than the English NHS. And what they estimated was that within Spain's NHS, you're looking at around about 25,000 euros per QALY at the margin of that system. The next study that was published was in Australia. So this is, again, this is Laura Edney and colleagues in Australia at the University of Adelaide. So a different group of researchers at a different university in a different healthcare system, different set of data, slightly different methods because they made use of some patient level data in this study. They came up with an estimate of $28,000 per QALY for the Australian healthcare system. And then finally, there was some work done in Sweden. So again, a different university, different group of researchers, published in a different journal. And they have an estimate of around 180,000 Swedish krona per QALY. So before we continue, we of course need to get these all in a common currency. So let's convert these into Canadian dollars. So here we have the four estimates. I've converted these into 2019 Canadian dollars. I've accounted for inflation. I've accounted for obviously differences in the value of currencies. I've accounted for purchasing power parity as well. Interestingly, by accounting for purchasing power parity, it's really the Spanish estimate that is affected here. If you don't do that final step, then the Spanish estimate is much closer to the others, right? In the region of $30,000 per QALY. When you adjust for purchasing power, then the Spanish estimate goes up to closer to $50,000 per QALY. You can see that none of these estimates exceed CADTH's current benchmark, which is $50,000 per QALY. Of course, these are in 2019 Canadian dollars. I wasn't able to inflate to a more recent year, but over time, of course, we can do that. And we can talk a bit later about how you'd expect inflation and various other factors to impact upon the cost effectiveness threshold. The median of these estimates is just below $30,000 per QALY. And again, before we continue, would we expect Canada's threshold to be the same as these international estimates? Well, no, of course not. There are differences in Canada's healthcare systems compared to these international countries. But we've limited it to those countries that are on the PMPRB 11. We've limited it to those studies that look at public healthcare systems. And so I wouldn't expect an estimate for Canada to be vastly different from these estimates. Okay, so another thing to consider is, until now, we think about calculating the ISA for a technology and comparing it to a cost-effectiveness threshold. And there is an issue with that language around threshold, right? It suggests that there is some kind of wall whereupon if you go beyond that, even $1, technology is $50,001 per QALY, well, then it's not cost effective. And that's no difference from if the ISA was 100,000 per QALY or $1 million per QALY. They're all just not cost effective. And in reality, if a technology has an ISA just above 50,000, then the impact on population health is very different than if the ISA was 100,000, which is very different than if the ISA was 1 million, right? That would have a much different impact on the health of the population. So I personally don't like thinking about this in terms of a threshold, right? This kind of black and white way of thinking about it. Are you this side of the threshold or this side? Personally, the way I would prefer to think about this is in terms of the impact on the health of the population, the net population health, right? Which is going to be different for various different ISAs above and below the threshold. So yeah, conventionally we take that ISA, we compare it to the threshold. I think that's unnecessarily restrictive. And I published an editorial a couple of years ago on why, in my view, we should actually abandon the ISA. It's got a whole load of limitations to it. And we should move on to using estimates of net benefit. And there's nothing new about net benefit. It's been around for 20 years or more, this concept of taking the same information that you have in the ISA and in the threshold, that incremental cost, the incremental benefit, and the threshold. You take that information and you rearrange it into an estimate of the net impact on population health, the QALYs gained minus the QALYs that we expect to be foregone. That's the net impact on population health. And the nice thing about doing that is that we move beyond this dichotomy, right, of just having a threshold. And we don't need to think of economic evaluation as being in isolation to the other factors of interest, right? Because there are always things that will go into that decision beyond the economic evaluation. There will always be. And by thinking in terms of net health benefit, it's much easier, I think, for a decision maker to then trade this off with other considerations of value. Right? If you do an economic evaluation and you find the ISA is just above 50,000, maybe this is a drug with a very small budget impact. Right? It might be that the net impact on population health is negative, right? Because the ISA is above that threshold. But it might only be slightly negative, and there might be other compelling reasons why we'd like to reimburse that technology. On the other hand, if you have a medicine with a very high budget impact, and you have an ISA that's substantially above 50,000, well, there could be a very, very substantial net loss in population health, to the point where perhaps there aren't any other factors that would justify a positive recommendation, right? It's up to the payers, it's up to PCPA in the negotiation, it's up to the payers to think about all these other factors beyond economic evaluation that they'd like to take into account. But we can really facilitate that by using net health benefit, right? Think about the net impact on population health rather than ISAs, right? I think our job as health economists is to facilitate those discussions rather than try and pretend that this is the only consideration, which of course is not the only consideration. Now, what about equity in the distribution of population health? Because so far we've been assuming that a QALY is a QALY. What if that's not the case? What if we have these expected health improvements and expected health losses? And what if some or all of the patients who stand to benefit have characteristics that we wish to prioritize, right? So what if some patients have a very severe illness, for example? It might be the case that society wishes to put a priority on the health of those patients. And even if the QALYs that are expected to be gained are outweighed by the QALYs expected to be forgone, as in this example, we are willing to pay the price necessary to get that technology because the patients who benefit have particular characteristics, severity of disease, or some other characteristic that we wish to prioritize. And we can do that, right? In order to do that, we need to use something called distributional cost effectiveness analysis. And we can do it by applying direct equity weights to the QALYs. If anyone's interested in this, there was a textbook that was published, again, just a couple of years ago by a number of editors from around the world. The editor-in-chief was Richard Cookson, who's a leading expert on this at the University of York in the UK. And myself and James O'Mahony and Jeff Round at the IHE co-authored a chapter on direct equity weights, chapter 14, where we talk in some detail about how you can do this, right? How you can assign equity weights to the QALYs gained for certain individuals. The challenge in Canada would be establishing those equity weights, right? So I'm not aware, as of now, of any research that was really compelling research that has said that certain characteristics are worthy of a higher equity weight than others, right? Research would need to be done. There's also another problem which we elaborate on in this chapter, which is that it's all well and good applying equity weights to the expected health improvements, but we also need to consider whether some of the patients who stand to lose health have characteristics that we wish to prioritize. So you could well have patients who stand to lose out who also have a severe disease, right? If let's say that we have an equity weight for severity, well, some patients who benefit have a severe disease, some patients who lose out have a severe disease. We'd have to understand the proportion, right, of those patients who stand to lose out that have that characteristic. Another factor that has not been given enough attention, in my view, is about the socioeconomic characteristics of those patients who we expect to lose health. Right, so imagine that we spend a lot of money on a new technology. We have to reduce spending elsewhere in the healthcare system, right? And there's either much longer waiting lists or we have delisting elsewhere in the system. Who is going to suffer the health losses as a result of that, right? So most of the people on this call, I would imagine, have some form of private supplemental healthcare. If the public system was to no longer fund a treatment that you rely on, potentially you could use the private insurance that you have through your work to cover the cost of that. If you're particularly rich, you could go to the United States and skip the waiting list here in Canada. If you're in the lowest socioeconomic group, those options might not be available to you, right? If you don't have a job that provides private health insurance. And it's those patients who I think are going to bear the brunt of the health loss that arises when we reallocate resources, right, towards new interventions. So if we care about equity, we really need to think carefully about who the individuals are who stands to lose health. And it could well be that we are exacerbating existing inequalities in healthcare, right? Because those who are in the lowest socioeconomic groups are often have the worst health outcomes to begin with. And what about a societal perspective? I'm going on a very quick tour of a number of different issues which potentially impact on the cost effectiveness threshold here. And if anyone wants to talk about any of these topics in more detail, there'll be plenty of time after the presentation. So what about a societal perspective? It's something that's gained a lot of attention recently. And there are good reasons why you may wish to adopt a societal perspective, particularly in pediatric care. The benefits of an intervention can go far beyond just the health benefits that arise. There could be benefits for the carers who can now return to work, productivity benefits, be educational benefits, you name it, right? There could be a whole load of other benefits beyond just the health benefits. So we're no longer interested in just expected health benefits. We're interested in expected societal improvements. But again, just like with the equity weights, we really need to think about how this impacts on that opportunity cost. So if CADTH were to adopt a societal perspective, its consideration of opportunity cost would now need to be broader, right? It's no longer just the QALYs that are foregone elsewhere. For each of those QALYs foregone, you have a patient, a real patient, who now has worse health than they did before. Maybe they are less productive at work. Maybe they now need a carer that they didn't need before, right? And so that carer, that other person is now affected. That carer is going to be less productive at work. There's going to be productivity and consumption losses, potentially an impact on private insurers, because maybe that person who's lost out health elsewhere is now putting a greater strain, if you like, on their own private insurer, right? They're imposing costs on that private insurer. So there's going to be a variety of impacts beyond health on that opportunity cost side of the equation. It is not only on the benefit side where a societal perspective will impact on how we value the outcomes. And that there have been at least one or two studies in the US recently that have looked at economic evaluations done from both a healthcare payer perspective and a societal perspective. And they've concluded that those studies that report both, usually the ISA is lower from a societal perspective, which is not a surprise because you're throwing in additional benefits, right? In addition to health outcomes, you've got consumption benefits, productivity benefits. And then the conclusion is, well, as a result of that, the technology appears more desirable from a societal perspective, right? The ISA is more favorable, that kind of language. We have to be really careful because from a societal perspective, that opportunity cost is now broader. And it's quite possible that the technology is actually less desirable, even if the ISAs are lower, because the value of that opportunity cost is now much greater. And in fact, if we take this a step further, we need to think about, well, if the perspective was changed to a societal perspective, but the budget of the healthcare system is not changed, which is what would happen here in Canada. Canada switched their perspective, but provincial budgets were not increased. You have to think about, well, at any one moment, the net budget impact of all of the health technologies and services that can be considered cost effective is constrained by that budget. So if we change the perspective, that will not increase the net budget impact of those technologies that can be considered cost effective. It will change the composition. There will be some technologies that were not cost effective before and they are now. There'll be some technologies that were and they're now not, right? So that the kind of the rank ordering, if you like, of the technologies will change. But it cannot be the case that switching perspectives makes more technologies appear cost effective than before. When I say more, I mean a greater net budget impact of technologies appearing more cost effective. It's just not possible because the budget has not changed. So we need to be very, very careful before we move to a societal perspective to think about the implications for the opportunity cost. And there's a number of other things we need to be careful about the potential for discrimination, but that goes beyond the scope of this presentation. Now, what about demand-side estimates of willingness to pay? We've not talked about them yet. So demand-side estimates of willingness to pay, such as the value of a statistical life, are frequently higher than supply-side estimates of health opportunity cost. And there's a clear theoretical basis for this finding. And for those who are interested, I would refer you to this IHE report that was published about 4 years ago, that really sets out why you would expect a demand-side threshold to be different from a supply-side threshold. And the reason is that they are measuring different things, right? A demand-side threshold, typically, those studies are looking at how much individuals are willing to pay to improve their own health, right? The variety of different methods that are used, but that is basically what they're getting at. Now, you could think of your own willingness to pay to improve your own health, whatever that is. How much would you be willing to pay to improve the health of somebody else? It's probably lower. How much cost would you be willing to impose on the public health budget in order to improve your own health? It's probably higher because you're not paying anymore. How much cost would you be willing to impose on the public healthcare budget to improve the health of someone else? I mean, that's now a completely different consideration. And what about if you have to pay taxes into this system as well, right? You might not be willing to pay the taxes required in order that you can spend money at the margin of the health system to provide those qualities to somebody else. So you would not expect the supply side threshold, which is estimating that marginal productivity of the public healthcare system, you would not expect that to be as high as a demand side estimate of willingness to pay. And you occasionally see studies that say, well, if the supply side threshold is lower than the demand side, we need to increase the budget. The budget's inefficiently low, but it's much more complicated than that, right? In a democracy, you're very, very unlikely to ever get the supply side threshold up to the demand side threshold, because people would end up having to pay such a high level of tax to fund that more than they're willing to pay for their own health. And it's just not going to happen. So we have to be very, very careful not to conflate these different approaches. And you can show quite easily, and there's a number of papers that have done this, that using a demand side estimate as a threshold can diminish population health. And I'm not going to get into all the algebra here. If anyone's interested, I can give you papers that delve into the algebra. We'll just consider a very simple example. Suppose that a new health technology has an ISA of $60,000 per QALY, and that the health opportunity cost is estimated to be $30,000 per QALY. So that's in line with those international estimates I showed you earlier. And let's suppose that a demand side estimate of society's willingness to pay is $100,000 per QALY. Okay, so these are very, very simple numbers just to illustrate the example, but they're not actually that far off. But 30,000 certainly isn't far off those international estimates. There are studies that have shown six-figure estimates for willingness to pay from a demand side threshold. Now, if you were to just take that demand side estimate and use it as CADTH's cost effectiveness threshold, then CADTH would find the technology to be cost effective, right? $60,000 is less than $100,000. So technology is cost effective, right? Simple as that. Here's the problem with that. If you reimburse the technology, it would diminish population health at that price if there was no negotiation on the price. If you're at a price where the ICE is $60,000 per QALY, because every incremental $60,000 spent on that technology would result in 1 QALY of health improvement, but it would result in 2 QALYs of health losses because a QALY is forgone for every $30,000 of incremental cost. So for every QALY gained, you'd expect to lose, obviously this is uncertain, you would expect to lose 2 QALYs elsewhere. So it would diminish population health. And it gets worse than that because that demand side threshold, what's the purpose of that? It's certainly not to estimate the health opportunity cost. It's not designed to do that. The purpose of a demand side threshold is to value health. So there's a whole load of debate about whether a demand side threshold elicited using these methods is an appropriate, is a legitimate estimate of society's willingness to pay for health. There's a big debate about that. But let's just suppose, for the sake of argument, that it is legitimate to use a demand side threshold to value health. What does that mean? Well, in this case, you would value the health gains using that demand side threshold, but you'd also have to value the health losses. And in this example, those health losses are double the health gains. And that means that the value of the health losses is double that of the health improvements. And there's no way of getting around this just by using a higher value of the demand side threshold. So in this example, we've used $100,000 per QALY as that demand side threshold. If the demand side threshold were higher, let's say 200,000, well, it's going to double the value of the health gains, but it's also going to double the value of the health losses. So the absolute value of the net loss in population health is now greater than it was before, right? So this might seem kind of counterintuitive that in actual dollar terms, the net monetary benefit actually declines as you increase that demand side threshold if you're in a situation where the ISA is greater than the supply side threshold. If you're in a situation where we are expected to forgo more QALYs than we gain, just increasing the demand side threshold does not make the technology cost effective. It just exacerbates the value of that health loss, by the absolute value of that net loss in population health. Okay, so I'm going to finish with some recommendations that I have, my own opinion for what CADTH should do in this situation. So Canada's behind other countries in doing this research. That systematic review that I showed you earlier, there weren't any studies from Canada. And the reason that we're focusing on international estimates is because that's the best thing that we have right now in Canada. So I think CADTH and the CIHR should support empirical research into the health opportunity cost associated with reimbursing health technologies in Canada's public healthcare systems. You know, historically, CIHR has not been interested in this sort of work. And it's a real shame because ultimately it's, you know, health economists talk about foregone QALYs, and it's easy for those who are not economists to their eyes glaze over, you know, what's a foregone QALY and opportunity cost. Ultimately, this is about patients. This is about Canadian patients who now have worse health outcomes. And at the very least, we need to estimate the impact on their health, right? Usually, when a decision is made, a recommendation is made to fund a new technology, we don't know who those patients are. So those patients, I mean, imagine that you're on a waiting list. Imagine you get assigned to a waiting list that's 6 months long. Do you know when you get put on that waiting list that the waiting list would have been 5 months long if only we hadn't paid for some technology in the previous budgetary cycle? You wouldn't have any idea. You've got no idea that you have borne the opportunity cost of some other decision. So those patients on the health loss side of the equation, they don't have any say. They don't have any voice in the decision. And the bare minimum that we can do is try our best to estimate what the impact is on their health using the best measure that we have, right? Currently, that's the QALY. A lot of people criticize the QALY. If you can come up with a better measure of health than the QALY, fine. We're now going to measure that health loss using that alternative measure of health. It doesn't change any of the principles in this presentation if you were to use an alternative measure of health, right? Ultimately, this is about measuring the health of patients. And I think this should be a priority. Right? In the UK, the NIHR funded the work at the University of York a decade ago, right? And we haven't done it yet in Canada. So I think this should be a priority. If we did this and the work was done and it was published, it would allow CADTH to adopt an evidence-based cost effectiveness threshold, right? It gives at least some voice to those patients who are impacted by the incremental cost of new treatments. If we believe that every patient who's affected by a recommendation should have a voice at the decision-making table, then we have to do this. In my view, you wouldn't just stop there and use this as a threshold and compare an ISA to the threshold. I would use that, I would recommend that CADTH use that to estimate the net impact of reimbursement on population health. And CADTH can do this for the list price. They can do it for various different price reductions, as they do currently. But instead of just reporting the ISA at various different price reductions and calculating the percentage reduction needed for the ISA to equal 50,000, what they can do is say, you know, at various different price reduction scenarios, here's how this technology would impact the health of the population. And that's, in my view, a much more useful estimate to then start trading off with other things of value to decision makers that are not included in the economic evaluation. It means the economic evaluation is no longer in a silo, right? We can actually sort of have a much more sophisticated way of thinking about the value of a technology that incorporates things beyond the economic evaluation, but also does not ignore what's in the economic evaluation, because that's incredibly important, what is in the economic evaluation. And finally, what do we do in the meantime? Because this research will take time to complete. And right now, there isn't any evidence from comparator countries that would support increasing that threshold above 50,000. None of those studies in PMPRB 11 countries that have been published today would support raising CADTH's threshold. Now, you might point to the median as being 30,000 in those other countries, and maybe we should lower CADTH's threshold. Personally, I would say let's wait until we've got Canadian data that would support that. The last thing you want to do is lower the threshold and then you do the research in Canada that makes you then raise it again or lower it further. You need to have some kind of consistency, a clear line for manufacturers. So I think there is merit in keeping it as it is, recognizing that it's not evidence-based, prioritizing that research, and then at the earliest opportunity, moving towards an evidence-based threshold, recognizing as well that the economic evaluation is not the be-all and end-all, it's not everything. So we're not going to use it as a hard threshold. We're going to use it to calculate the net health benefit, and that's going to inform the decisions that are made by payers. And I'll stop there. Well, I'll leave the screen up with these recommendations and be happy to have a discussion. Thanks very much.
So thank you, Dr. Paulden. So we'll now invite attendees to use the Q&A function in the Zoom software menu. So you should find that at the bottom bar of your screen on most screens. And anyone with further questions after today's webinar is encouraged to email noah@iag.ca. So while everyone's getting their Q&A questions started, I'm going to start with a question of my own. So it's related to point 3, recommendation 3. Kind of around the stated threshold. So you talked about calculating net population benefits at a variety of different prices, but we know that by stating a threshold, we're kind of anchoring sponsors to the value-based price. And we know that when we do that, we're kind of treading water in terms of the marginal benefits to the population. So what do you see as some possible solutions to that?
Okay, great question. Okay, so for those who think what's everyone talking about treading water, so if you read a textbook model of how you should establish a threshold, you'll see a kind of a league table approach, right? A whole load of technologies with different ICEs, and the kind of the theory in the model, which never happens in practice, but the textbook model says you adopt technologies with ICEs at the bottom, the lowest ICE, and you go all the way up, and when your budget's exhausted, well, that's your threshold, right? Now, it doesn't happen in practice for a variety of reasons, right? One of which is that we don't have perfect information about the ICEs of every technology. But there's another reason, which is that the moment the public healthcare system says, this is our threshold, NICE in the UK, which has had an explicit threshold for a long time, we're willing to pay £20,000 to £30,000 for a quality. At that point, if you're the manufacturer of a technology which has a lower ISA, say 10,000, why? Why are you keeping the price there? Like, you're leaving profits on the table. You might as well raise your price to bring the ISA up just below that threshold, and you'll make a lot more profit, and it'll still be considered cost effective. So there's an endogeneity. Once the threshold has been publicly announced, there's an incentive for manufacturers to price up to that threshold. And this is not a new concept. There's lots of people that talk about pricing up to the threshold. In Canada, there isn't so much pricing up to the threshold. What you have is pricing way above the threshold in a lot of cases, not every case, and then a negotiation by PCPA down to maybe the threshold. We don't know. It's confidential what PCPA do. But we're talking about, we've gone beyond pricing. We've gone beyond having exogenous prices in the textbook. We don't have that. And we've gone beyond pricing up to the threshold imperfectly. And we're at a point where we're pricing way above, and there's a negotiation down to that. Now, if there is pricing up to the threshold or a negotiation down to the threshold, if you end up with the ISA equal to the supply side threshold, then when Erin said treading water, what she means is that every quality that you gain, let's say that the ISA and the threshold are $30,000 per quality, for the sake of argument. Every $30,000 you spend, you gain a quality. but that $30,000 could have been spent elsewhere to gain a QALY. So you gain one QALY, but you lose one QALY, and the net impact is zero. You're treading water in terms of population health. Now, personally, I think it's a problem if over the lifetime of drugs, including the off-patent period, if the net impact on the health of the public is zero or negative. I don't think that's what Canadians expect. I don't think that we expect that when payers make risky decisions to fund new technologies, and they are risky because the evidence is uncertain, that the return in terms of population health would be negative, right? We often talk about the return for manufacturers, right? You need a price high enough. The manufacturers not only make a profit, but they make a return, a sufficient return on their investment in order to incentivize further research and development. Well, think of the return from the public healthcare system, not in dollars, right? The public health system is not there to make a profit. The public healthcare system is there to improve the health of the public. And it's entirely reasonable to expect when a risky investment is made that there is a return, a positive return, in terms of population health outcomes, which would require that you gain more health than you lose. So you'd want to end up with a price at which the ISA is lower than that supply side threshold, right? But this is a relatively new way of thinking, right? There's very, very little research on, what the optimum point would be, right? Below that supply side threshold. But it is a way of I think, a new way of thinking about this in terms of what are the returns to manufacturers and what are the returns to the system. And a fair price is one that results in positive returns to both sides, right? To manufacturers, they make a profit, and the healthcare system gets to improve the health of the population. That's where a fair price is. So we wouldn't want a price that results in just treading water, right, in terms of population health outcomes. Does that answer your question, Erin?
Yeah, no, that's a great answer. I think everyone can refer to that IHE report from 2018 if they want to see what a nice model of that looks like. Okay, so I've got a few more questions. So first is from Sasha Van Katwick, who's here at IHE. So his question is, recognizing your framing of health opportunity cost, is it not the case that any CADTH threshold would vary across provinces?
Yes, so the short answer is, let's modify CADTH threshold. The short answer is the supply side threshold would be different across provinces, right? That estimate of the marginal productivity of the budget varies across provinces. It even varies across budget silos within a province, right? So that's something to think about, that if there is a silo of budget for cancer and it's relatively generously funded compared to another budget silo, let's say for mental health, it's quite possible that what we call the shadow price or the marginal productivity, that cancer budget corresponds to a higher cost per QALY than the marginal productivity of the mental health care budget, right? So just give an example, right? Every province just allocates their budgets in different ways. So this is just very kind of stylized. But yes, within a province, you could have different supply side thresholds for different budget silos. And of course, across provinces, right? You see that different provinces have different willingness, different ability to pay for healthcare. Funding per capita is much higher in Alberta than it is in some of the Atlantic provinces. I would expect that you would have a higher supply side threshold in Alberta than you would in Prince Edward Island, for example, right? Now, what do you do about that? Because it's probably not tenable for CADTH to have multiple thresholds for every province. Like, probably not. People are just not going to understand it, and there's then a loss of transparency and credibility if that's the case, right? I mean, personally, if it was up to me, I would say if you identify that in the Atlantic provinces, because the budgets are lower per capita, they're not able to spend as much at the margin. We ought to reallocate resources in such a way. If we think this is a problem, an equity problem, you address it not by fiddling with thresholds. You address it by reallocating budgets so that the supply side threshold is equal across different provinces. If you don't do that, then it actually reveals something about whether we're okay with that inequity, right, across Canada. I don't know whether I completely answered. So the question about CADTH threshold, I think pragmatically, CADTH can't have multiple thresholds. It wouldn't be feasible for CADTH to say this technology is cost effective in Alberta, but it's not in Nova Scotia. Can you imagine that? Like but the reality is the putting politics aside, right, in terms of the actual data, the empirics, the science, yes, the impact that a certain cost has on the health of patients will be different across provinces. That is true. So there's then the politics about how you handle that.
Yeah, super interesting. Okay, so our next question is from Andy Chuck. So he asks, in Canada, we don't have a national health service. It's really up to provinces. So it's also likely that each province has a, I'm reading this now and seeing it's a very similar question. So acknowledging that CADTH and CIHR won't fund this empirical work, what about finding a coalition of the willing and perhaps working with the province? Would IHE and other local funders perhaps consider something for Alberta?
I didn't see Andy's question, and you basically have just my answers to the previous one was Andy's question. So yeah, I think you're right, Andy. I think you're right that's pragmatically the way to do this in Canada, is to estimate thresholds for those provinces where there's the willingness to do it, also the data to do it. Remember that the data is kind of fragmented across Canada. Some provinces have better data availability than others. I believe that to be the case. Let me know if that's not the case. So it might be more challenging to estimate a threshold in some provinces than others. I do think we skipped a question, Erin, didn't we? I think there was one that was just a minute, an anonymous question just before Andy's. Should we go to that?
Yeah, sure. I'll go to that one. So this question is, I apologize, but I am still a little unclear about the advantage of using net health benefit over ICER that Dr. Paulden spoke about during his presentation. So could you speak about this a little bit more? Both use incremental cost, incremental effect, and a willingness to pay threshold, but a rearranged formula. What makes one more advantageous to the other?
Great question. So if you want to know more about this, Google why it's time to abandon the ICER, get that paper, and I sort of go through some of these different reasons. But basically, if life were extremely simple, if there were only two strategies, intervention versus a comparator, there was no uncertainty, then these are equivalent, right, using these measures. The issues come from the number of issues. One would be you've got multiple different strategies, and you end up with ICERs, you have you have to calculate multiple pairwise comparisons using ICERs, sequential ICERs, as CADTH calls it. It becomes extremely laborious to actually do that. You don't need to do that with net benefit. With ICERs, you need to start ruling things out through dominance and extended dominance, and that raises problems. We can talk about that. It's possible for a dominated or extended dominated strategy to be more cost effective than a strategy that's on the efficiency frontier. It can never be more cost effective than the most cost effective strategy, right? That can never be dominated or externally dominated. But the second most cost effective in terms of net benefit could be dominated or externally dominated. And the worst strategy in terms of net benefit could lie on the efficiency frontier. That is possible, right? So dominance, extended dominance can be quite misleading if you actually want to move beyond that paradigm of winner takes all and there's only one technology. You want to think about, well, what if we offered a choice of strategies to patients? You need to think in terms of net benefit, right? You can't use ICERs. When you deal with uncertainty, ICERs are problematic because they're discontinuous about the vertical axis. So as you approach that vertical axis of the cost effectiveness plane, ICERs approach positive infinity and then begin at negative infinity, right? So what do you do about confidence intervals when you deal with that? There's a whole issue around that. In terms of uncertainty in the threshold, this is something that hasn't received enough attention. I should really publish something on this because I don't think there's anything out there, but I'll talk about it anyway. If your threshold's uncertain, we've just been talking about how this empirical work is uncertain, right? The methods are evolving. Anything that's empirically estimated, you would never know with certainty, right? So the Claxton work in the UK had a whole appendix on the uncertainty in that estimate. Now, if you use a net benefit approach, you could, and again, I've not seen this done, but you could incorporate the uncertainty in the threshold into your model. Think about each Monte Carlo simulation. You could run Monte Carlo simulations over the threshold and actually account for the uncertainty in the threshold in addition to the uncertainty in all of your other inputs, like your cost inputs and utility inputs and other transition parameters, right? You could then report that to decision makers. This is the overall uncertainty, right? Given uncertainty in the threshold. How can you do that if you're comparing the ICER to the threshold? Because when you do that, all of the burden of thinking about uncertainty in the threshold is on the decision maker doing the interpretation, right? You're reporting an ICER and any complexity in the threshold. I mean, how would you even do that? I don't know how you do that. So there's a real advantage to using net benefit in that context, because the analyst can deal with all the complexity of the uncertainty in the threshold and just report the net benefit, which is super simple to interpret. Positive incremental net benefit's a good thing, negative's a bad thing, right? So it's super easy for the decision maker to then interpret that. But you ask a decision maker to take account of uncertainty in the threshold when you give them an ISA, and how are they going to do that, right? So the whole, but equity weighting, right? Equity weighting, you can do that in a disaggregated net benefit framework. You can say it's not just qualities gained and qualities forgone. We disaggregate the qualities gained into who gains them, and we disaggregate the qualities forgone into where it's forgone, and we can start applying equity weights to it. If you are using an ISA framework, it's very difficult. NICE has tried this. NICE has tried applying equity weights, effectively weighting the threshold instead of the qualities. And in doing so, they have not taken account of the opportunity cost, because they've assumed that an equity weight translates directly to a threshold weight. You know, quality weight translates to a threshold weight. That's not the case. We talk about that in the chapter in the Cookson textbook. So a whole load of issues that come to play once we move beyond the paradigm, sort of 1980s, 1990s paradigm of there's only two strategies, we don't care about uncertainty, you know, threshold is fixed and constant over time. Fine, in that case, just use an ISA, right? But if we want a more sophisticated economic evaluation, which accounts for uncertainty, which accounts for equity weighting, you have to move to a net benefit framework.
Okay, thank you. So we have 3 minutes left, and we have one question that I'd like to fit in if we can during the time we have. So this is from Dat Tran at IAG. So Claxton et al. Recommended a threshold of 30K in Canada in 2018. So I think he's talking about the AHOLIC PMPRB report. Right. Should that be considered, or why wasn't it discussed today?
So at the time of that, there wasn't anything in Canada, and the PMPRB at that time had responsibility for thinking about cost of equality. They don't anymore. That's a whole other debate. So they asked the York team, because they'd been doing not only the work in the UK, but they'd also been estimating thresholds for other countries, and they had a method for doing this. They asked them to use that approach to estimate what the threshold would be in Canada. The thing to remember about that study, though, is that it didn't use all of the Canadian data that you would like to use when doing that sort of estimate. It relied on some comparisons to other countries, essentially. It's a few years since I read this, but essentially, you know, like Canada's GDP is higher than this country's, life expectancy is higher, so you'd expect the threshold to be high. It's a lot more complex than that, but that's the idea. And so it's not quite as, I guess, robust an analysis as you would get if you did what they also did separately in the UK, which is to use UK data, do an econometric analysis to estimate that relationship at the margin between expenditures and outcomes. You need to do that in Canada, I think. And just after they published this 30,000 estimate, at the time I was chairing a working group for the PMPRB, a technical working group. We considered that estimate, and the kind of view among the working group was that really some of the assumptions that were being used, it's really quite uncertain, this 30,000. You know, we weren't really confident in saying to the PMPRB, yeah, this is a solid estimate, you should go and use it. So it's, by happy coincidence, that 30,000 just happens to coincide with those 4 studies that I showed earlier, right? The median of those 4 studies. So actually, I suspect they got the right ballpark with that 30,000. But in order to know for certain, we'd have to do the work here in Canada.
Okay, well, fingers crossed we can do it sometime soon. Okay, so thank you, Dr. Paulden, for your presentation, and thanks to everyone online for taking time to attend today's seminar. You can subscribe to NOAHE by visiting noah.ca for news on upcoming events. So thanks again for attending. Bye, everyone.
Thanks very much.